with this program, a full program, and would like to thank all. Sorry about that. So I pray that we all have a pleasant time of learning from our local and our international speakers, and hope we'll be able to attend the full day. All the best to everyone. Thank you very much. I think the session chair, Dr. Ngwari, you can take over now.
Thank you, Dr. Magore. Thank you for that welcome message. Are we on time or we are early? Should we start now or we wait for 8:40?
Morning, Dr. Ngwaru, Dr. Mateke, and morning, everyone. For those of you who don't know me, I'm the Society Secretary General. I think we are right on time, Chairman, and the first speaker should be starting at around 8:40. And maybe in the meantime, you can just take a bit of time to maybe introduce our first speaker to those who have already joined while she prepares for a presentation.
All right, thank you, Dr. Mateke. So my name is Dr. Stanley Ngwaru. I'll be the chairperson for this session, the first session. A bit of some ground rules for this session. I kindly remind members to stay on mute unless they have something to say, so that we can avoid background noise. So if you're not presenting, may you please check that you're on mute? Hello? If all members who are not presenting at the moment, if you can put your device on mute so that you don't have a background noise. And those who will be unmuted, who will be presenting, may we find an environment where there is no background noise so that we can avoid background noise also. And those who are joining, we also kindly remind you to join using audio instead of video, unless you are the presenter, so that we don't have network challenges. We also remind you to make your contribution, your questions, keep them short and precise so that we can move. And we also encourage members to post questions in the chat box so that we can look at them and the presenter can answer them. Some of the questions the presenter can answer as they present. And we have a question and answer session at the end of the presentation. Having said that, I want to welcome you all to this first session for this annual general meeting for Zimbabwe Society of Obstetricians and Gynecologists. This first session is going to take us to 11 o'clock, and we are going to look at HPV-related diseases, room for improvement in screening and treatment. It's a privilege and an honor to introduce the first speaker for this session. It's Professor Lynette Denny. She's a gynecologist oncologist. She still practices in clinical gynecologist and oncology. She has worked, she has done extensive work in alternative strategies for prevention of cervical cancer in low resource settings. She has worked in many countries, including South Africa, Ghana, Nigeria, and United States of America. She has worked on prophylactic HPV vaccine on trials, and she has pioneered the trials for these HPV vaccines. Currently, she's the director of the SA Medical Research Council on Gynaecology Cancer Research Council. Prof. Dean, I want to welcome you to our annual general meeting, and you can take the floor to present your presentation on cervical cancer, on HPV genotyping. Thank you very much.
Thank you so much for that kind introduction, and thank you very much for the invitation to join you. And as you know, Dr. Gusha trained in our unit, so it's really a pleasure for me to participate in today's Zimbabwe Society of Obs and Gynae annual conference. So I'm just so thank you very much for that. I'm just going to share my screen. I just need to, sorry, I just need to get the, can you see it? Can you see my slides?
Not yet.
Not yet, Doc.
Not yet, okay. So let me just get, sorry to waste your time here.
No, it's okay. We're still on time. We're 10 minutes early, Prof. So take your time. You're supposed to start at 8:40. So I think.
Okay, so I have the presentation open. So then I just push the green share screen, do I?
Yes.
I don't know why I'm struggling to get this up. Do that. There you go.
Right, something is happening now.
Something seems to be, right?
There we are. There we are. We can see the screen now, Prof.
Can you? Oh, goodness. Thank you.
Thank you so
You're
much.
on.
Yes.
I'm on. Okay, good. And you can hear me.
We can hear you loud and clear.
Okay, so just to show you, this is my hospital, Critis Care Hospital. And this is my research site on this other side of the picture, which is in a very poor township called Khayelitsha, where we've managed to screen over 40,000 women in various research enterprises. So just to give us a global perspective of cancer, which comes from the 2018 data, there were 18 million new incident cases of cancer with just under 10 million deaths. And cancer incidence and mortality is growing throughout the world, including in Africa, partly due to aging and population growth. There's also been a change and prevalence of risk factors. Socioeconomic development and westernization of lifestyle is a contributor. Lung cancer is the most commonly diagnosed cancer for men and women and a leading cause of cancer death. And in women, most commonly diagnosed cancer is breast cancer, followed by colorectal, lung, and cervical cancer, which is the fourth most common and in incidence and mortality. But if we look at the distribution of cancers by region and by proportion of the world's population, you'll see that Africa has around, Africa has about 6% of the world's cancers and harbors 16.9% of the world population. The highest incidence of cancers are in the Americas and in Europe. And just to give you an overall perspective, breast cancer is the second most common cancer in incidence, but the fifth most common cancer cause of death, which shows the improved detection and treatment of breast cancer. And if we look at the estimated number of new cases in 2018 worldwide amongst women, you can see that cervix is the fourth most common cancer at a nearly 570,000 cases. If we look at the number of deaths worldwide amongst women, cervix cancer again is the fourth most common cause of death from cancer. And if we look in the Afro region, however, although cervix cancer is not necessarily the most common cancer, it has a very, very high mortality compared to breast cancer, and proportionately more women die from cervical cancer than from breast cancer in Africa. And this just gives you a picture where breast cancer is the most common cancer in 156 countries compared to 27. And in terms of mortality, breast cancer is the leading cause of death in 104 countries versus cervix cancer, which is the leading cause of death in 44 countries, largely in sub-Saharan Africa. So the age standardized incidence rates range from about 4.4 cases per 100,000 women in Western Asia to 42.7 per 100,000 in East Africa, which is a huge difference. And similarly with the age standardized mortality rates. And the overall disability adjusted life years that are lost attributable to cervical cancer was 6.9 million years in 2013, with 84% occurring in less developed regions. Cervical cancer ranks second in incidence and mortality and low Human Development Index setting, where it is the leading cancer in women in 27 countries and the leading cause of cancer death in 44 countries. If we just look at the basic epidemiology of cervical cancer, we know that persistent infection of the cervix with high-risk types of human papillomavirus are essential to the development of cervical cancer. We also know that more than 200 types of HPV have been identified, of which 12 have been strongly associated with cervical cancer. And I'm sure you're all familiar with type 16, 18, 31, 33, 35, much more common in Africa than in other parts of the world, 39, 45, 51, 56, 58, and 59. The most carcinogenic are 16 and 18, and based on multiple meta-analyses and systematic reviews, the global presence of HPV is estimated at around 12%, with the highest prevalences in Africa and Oceania. Now, what's important about cervical cancer is that it is attributable to an infection. And in 2018, the global burden of cancers attributed to infections were, the four most important were Helicobacter pylori related to stomach cancer, high-risk human papillomavirus, hepatitis B, and hepatitis C. And in 2018, it was estimated that 2.2 million new cancer cases were attributable to infections. And the very high infection attributable cancer burden in sub-Saharan Africa is principally driven by HPV attributable cancers. I just need to move this out of my way, so it's blocking me. sorry. When we look at the age standardized global incidence and number of cancer cases attributable to HPV, you can see in sub-Saharan Africa, it's about 120,000 cases with an age standardized incidence rate of 19.3 compared to globally where it's 8 per 100,000 persons, with about 690 attributable cases. So papillomaviruses are found in humans and divided into 5 genera based on DNA sequence analysis, with the different types having different life cycle characteristics and disease associations. So the low risk alpha types, such as 6 and 11, are associated with genital warts and respiratory papillomatosis. Epithelial disease caused by HPV are linked to different strategies of transmission and propagation within the epithelium and their different interactions with the immune system. The most well-studied types are the alpha mucosal types, which are associated with cervical cancer, and the alpha types are divided into cutaneous and mucosal types. The mucosal types are further subdivided into high and low risk, and we've already mentioned the 12 HPVs that are types that are defined by WHO. HPV 16 is prominently associated with squamous invasive cervical cancer and HPV with adeno-invasive carcinoma, but each virus can affect both epithelia. So this is just a description of the different types of genera, the 5 that I've mentioned. And you can see that the cervical cancer types are all in amongst the mucosal alpha papillomaviruses that are associated with cervical cancer. HPV prevalence is highest in women under the age of 25 and declines in older women, but not actually in Africa and Asia, where it tends to persist in older women. HPV in various studies has been detected in at least half of the cases of cytologically diagnosed ASCUS, about 3/4 of low SILS, 90% of high SILS, with HPV 16 being the most frequently detected, with HPV 16 and 18 accounting for 70% of all cervical cancers, increasing to 90% if one includes types shown here, 31, 33, 45, 52, 58, 6, and 11 included. We all know that persistent infection with high-risk types of HPV is a necessary event. Up to 80% of sexually active persons over the age of 15 will be infected with HPV at some time. Transmission is by skin-to-skin contact. However, most infected individuals will clear their infection within 8 months, and the infection will have no clinical consequences for that individual. However, a minority of infected individuals will demonstrate significant HPV-related disease, which ranges from genital warts, which, as many of you know, can be as bad as cancer in terms of the destructive effects, respiratory papillomatosis, which has a mortality rate of around 3%, anogenital invasive disease and or precursors, and head and neck cancers. When we consider the cancer cases attributable to HPV by site, these are data from 2012, the attributable fraction to cervix was 100%. HPV was associated with 88% of anal cancers, about 1/4 of vulval cancers, and that number is increasing, about 80% of vagina, about 50% of penile cancers, and the others around, about 30%. So overall, it's about 1.2 million cancers associated with HPV. And if you look at the relative contribution of HPV 16 versus the other types, it is particularly high amongst women with cervical cancer. Than it is, in fact, in men. We did a study looking at the HPV prevalence and type distribution in women with invasive cervical cancer. We had 659 women from Ghana, Nigeria, and South Africa, of whom 570 had histologically confirmed invasive cervical cancer with an HPV positivity rate of 90%. And of those with a single type of HPV type identified, by far the commonest was HPV 16 at 51.2%. So HPV infection was actually more likely to be multiple types in HIV positive women, and HPV 35, which had a prevalence of 8.7%, is not actually included in any available HPV vaccines. And that is partly because all the research that went into developing the vaccines was in fact done in Europe and the North America, and not in Africa. What is the role of persistence in the development of CIN3? So there was a study by 8,600 Danish women who were screened twice, 2 years apart, using pap smears and a swab for HPV testing using hybrid capture and line probe assays for genotyping. And the development of CIN3 within 12 years in women who started with a normal cytology, but with an HPV infection, was within that space of time, 26% who had an initial HPV 16 developed CIN3. The risk of CIN3 with high risk HPV types other than the 4 above was about 6%, so very much lower. And the risk of CIN3 in women who were HPV 16 positive in both screening rounds was 47%. Women negative for high-risk HPV using hybrid capture was only 3%. So I just wanted to show you this picture that, infection is believed to start by, I'm sure you're all very familiar with this diagram, that you need microabrasions for the HPV to make contact with the basal cells. And initially, it infects in the episome. It is in an episomal state. And then as the persistence progresses, the virus integrates with the human genome and then alters the whole cell proliferation cycle until eventually it breaks through the basement membrane, as you can see here, and becomes an invasive cancer. So these are just photographs. There's a normal cervix. It becomes infected with HPV. It then progresses to a high-grade cervical cancer precursor. As you can see, as you progress, the nuclear to cytoplasmic ratio increases dramatically from the normal state, and there's a normal squamous cell. Here's a high-grade cell, and then eventually it becomes malignant. So what is the percentage reduction in the cumulative rate of invasive cervical cancer in women? And this is work that was done in the 1980s on women aged 35 to 64 with an assumption that you would have 100% coverage of women in the target age group and all women with an abnormal cytology would get appropriate treatment. And the reduction in cervical cancer, if you screened all women once every year, was about 94%, with but requiring 30 pap smears. If you screened women every 2 years, it was 93%, but you needed to do 15 pap smears in her lifetime. If you screened her every 3 years, it was 91%, and 10 pap smears would be needed. And these three intervals are not statistically different, but even screening all women for 3 pap smears in a lifetime, 10 years apart, would result in a 2/3 reduction in the cumulative incidence of cervical cancer. And this really is rather remarkable public health information. I'm sure you're all aware that this WHO has a draft strategy called the 90-70-90 for elimination of cervical cancer by 2030. And I'll just throw in a quick advert. We are running a webinar on Tuesday, which is going to be 17th of November, is going to be World Cervical Cancer Elimination Day. And this strategy assumes HPV vaccine, 90% coverage of all girls aged 9 to 14 years, followed at 70%, the aim is 70% screening, 70% of women with a high performance screening test at least twice at ages 35 and 45, aiming for 70% coverage. And then for cervical cancer treatment or cervical cancer precursor treatment, 90% of affected women will receive coverage. So this is very ambitious. And I'm on a team with your colleague, Mike Chirengi, and we're working with the WHO to try and realize this dream. And yeah, so this is the draft strategy. So I'm going to just move on because I don't want to go over my time. Critical to the prevention of cervical cancer, if we really want to eliminate it, is that we need the widest possible coverage of women in the target population. We should screen all women at least once in a lifetime between ages of 30 and 49, possibly lower for HIV positive women. Which screening test to use depends on human, fiscal, and other resources, health system capacity and organization, and competing health priorities. We need to ensure that effective treatment of women with abnormal screening tests is accessible and available. We need to reduce clinic visits to enable greater adherence and screen and treat offers, a very promising algorithm. And all treated women should be followed at 12 months post-treatment, and in an ideal world, for at least 5 to 10 years to detect recurrence of disease. In terms of cervical treatment, cervical cancer precursor treatments, ablation has once more become in favor. Historically, there was electrocautery. I grew up learning laser ablation. We also have cryotherapy, and now thermal ablation has become popular and is being used in mostly research settings. And then there are excisional procedures, which range from LETs to a cone biopsy. This is the Ligo thermocoagulator that we use. I can fit it into my shirt pocket. It's battery operated, it's rechargeable, and it's highly portable and in fact quite reasonably priced. The problem with cryotherapy is that you need the gas, and getting gas to many settings is very difficult, and it's quite cumbersome, but it is an effective treatment if you have the resources for that. So the traditional approach to screening has been, performing a pap smear, if abnormal, referring for colposcopy, at colposcopy, a confirmatory biopsy, followed by treatment and then follow-up. This really is unsustainable in poor countries, and we really need to be able to provide treatment for screen-detected cancers to be effective. This is a photograph of a patient with cervical cancer. This is a VIA photograph provided to me by Dr. Sankar, who many of you will know, and you can see there is an acetyl white lesion outlined by white. And this is a more dense acetyl white lesion, and the whole lesion can be visualized. We performed a randomized controlled trial in which we screened and treated women using human papillomavirus detection, hybrid capture, and VIA, and followed these patients up, and at 3 months, the sensitivity of HPV testing was about 90%. Sorry? Is there a problem?
No, Doc, you can go ahead, sorry.
Oh, okay. The sensitivity of HPV testing followed by treatment for CIN2 plus was 90% for HPV, but only about under 50% for VIA. Both had a very high negative predictive value, which is important in screening. When we compared these two strategies for the prevention of cervical cancer, we found that in the HPV compared to the control group, the proportion of disease prevented was 73%. We needed to screen and treat 23 women to prevent 1 case of CIN2, compared to the proportion of disease prevented of 33% in VIA, and you needed to screen and treat 50 women to prevent 1 case of CIN2. And this is just showing it in a graph, and you can see that in the, this is the control group, the cumulative presence of CIN2 plus, sorry, at 36 months. This is in the VIA group, and this is in the control group. This is a study from Dr. Sankar, which involved 4 different groups, a group with HPV testing, cytology, VIA, and control. The control group were given just general information, and he was the first study that used cancer as an outcome, and the reduction in advanced cancer was statistically significant in the HPV group, as was the death rate compared to cytology, VIA, and the control group. So the critical findings were that a single round of HPV testing and treatment of positives was associated with a significant decline in the rate of advanced cervical cancer and deaths. There was no significant reduction in the rate of death in either the cytological or the VIA groups. And this point is extremely important. The age standardized incident rate of invasive cancer in women with negative cytology and VIA were 4 times the rate among HPV negative women, supporting the very high negative predictive value of HPV testing. Just to bring together the intersections of HIV negative women versus HPV positive women. This is the prevalence of HPV in HIV negative women, and this is the prevalence of HPV in HIV positive women. And you can see the difference, almost 50% in HIV positive women is HPV 16 versus about 16% in HIV negative women. And these are our patients, women with HIV versus women, without versus with HIV. And these are the numbers in the two groups. And you can see there's a marked difference between HIV negative and HIV positive women. So single visit screen and treat approaches utilizing HPV testing really could revolutionize cervical cancer screening in low resource, high burden settings. This approach is supported by the WHO with the aim of increasing coverage and linking abnormal screening tests to same-day treatment. So we are in an ongoing study in Cape Town. We've now screened about 4,500 women, trying to optimize the expert HPV test in both HIV positive and HIV negative women, and to develop an algorithm for single visit HPV-based screen and treat for cervical cancer prevention in South Africa. So the expert HPV assay, which I'm sure you're all familiar with from GeneXpert, it's a PCR assay that detects 15 types of high-risk HPV, and they come out in 5 channels, and each channel has what's known as a cycle threshold, and it gives you a kind of sense of the viral load. This is the test. It is, you just take a sample. This lady in this picture is our GeneXpert tester. She takes a pipette. She puts it into the cartridge. She can do, you can do it one at a time. You don't have to batch. And she's not laboratory trained. She's just trained on the job. So these are the 5 different channels, and you get a printout telling you what's going on. So according to the manufacturer's instructions, when we tested for the sensitivity and specificity for CIN2+, we found that in HIV positive women, the sensitivity of the expert HPV was 93%, compared to 88% in HIV negative women. But the specificity in HIV positive women was only 64%, which is very low and would result in a lot of over-treatment of women. So we did some modeling and calculations and worked out that if we only included the first 3 channels, we would maintain our very high sensitivity in HIV positive women and HIV negative women, but we would increase the specificity amongst HIV positive women to 70%. And then we went further and we optimized the cycle thresholds and found that we could actually get up to 80, sorry, let me go down again. We could get up to 82% specificity in HIV positive women. So the performance of the test in the detection of high-grade cervical cancer precursors has been much improved. And we've now tested this approach in just over 3,000 women. So what we've done is we've restricted the number of types that are tested for and increased our specificity to over 80% in HIV positive women. And we've optimized the cycle threshold definitions, which is really ideal. So patients come in, they do a self-sample, then have a clinician-taken sample. It goes upstairs where we do the test. We get a result within an hour. And if positive And if considered, we call it VAT, visible visualization and assessment for suitability for treatment. In other words, there's no evidence of cancer, the squamous junction is visible, the aceta-white lesion does not cover more than 75% of the surface. We then treat the nurse treats the patients with thermocoagulation. And we are still following these patients up. COVID, of course, got in the way, but it was found 94% of patients chose to have immediate treatment and found it to be a very acceptable method of cervical cancer prevention. So I think I'll stop there. I hope I haven't gone over my time. Thank you very much for listening, and thank you for this wonderful invitation.
Thank you very much, Prof, for that wonderful presentation. Thank you very much for that presentation. I've got a question here that says, thanks a lot for the talk. My question is, HPV tests are accurate, especially with negative results, but requires PCR machine not available in most Africa. Reasons why VIA is most used. I think it's a comment there, it's not really a question. I don't know if there's anyone with a question that we need to give to the Prof before we move on to the next presenter.
Stanley, can I ask something? Dr. Lanman from Newlands Clinic. Hi, Lynn. Thank you for coming. It's just amazing to see you. And thank you. Can I just ask two quick questions? When you're doing education at schoolgirl level, you pointed out condoms do not protect against HPV, because when we're talking about the whole HIV prevention, STI prevention, condoms are obviously important, but can we really say condoms are really not helpful at all for protection against particularly the oncogenic HPV? And secondly, in the private sector, we see lots of young girls in their 20s with oncogenic HPV and low grade, even high grade SIL. So should we be screening much earlier? You know, when I was at UCT, they said your first pap smear 6 months after the onset of regular sexual activity. How has that changed now, particularly with HPV? What should we be doing when we have the private sector?
Thanks for those questions, Ingrid. I mean, firstly, in terms of condoms, the condoms are about, there haven't been any direct trials, but from subset analysis, condoms are about 70% effective in preventing transmission. Remember, skin to skin, and you cannot protect the scrotum side, but the shaft of the penis, you can certainly protect. Condoms are certainly helpful in reducing transmission and also reducing viral load. And male circumcision also appears to be effective in reducing transmission and viral load. So I would still promote condom use with explaining that it's only going to prevent or reduce by about 70%. So that's in terms of that question. And then the second question was, about age of screening. So I mean, there've been very nice prospective studies following young people who start as sexually naive, and then you follow them over to 5 and sometimes even 10 years. The vast majority of HPV infections in a healthy population of young people will in fact regress on their own. So I do not think that we should be screening young people, particularly if you're using HPV. And there is the potential harm of obstetric complications, cervical stenosis, preterm labor. So, you know, my suggestion is in HIV negative, if you know HIV status, you should probably start screening at around 25, because lesions that you're going to detect then are mostly going to regress on their own. Up to 60 to 70% will regress. If someone is HIV positive, I think they should be screened at the initial diagnosis, and if normal, rescreened 3 years later. That would be my approach. You are going to miss cases, but you do want to minimize harm by overtreatment. Make sense?
Thanks, Lynn. That's great. Makes perfect sense. Thank you so much.
Sure.
Thank you very much, Prof. Thank you very much, Prof, for that. Hello.
It's Dr. Nyakabau. I just wanted to add on to what Lynn. Hi, Lynn. Thank you for the presentation. Very insightful, and it's wonderful to be in touch with you again.
Yes.
So I wanted to just reiterate what you have said in terms of carcinogenesis. To just say that the process of carcinogenesis takes a long time. So, I mean, when we are looking in terms of cancer causation, we would like to take that into consideration, the latent period from initiation of the carcinogenesis process to the time when you eventually get the cancer, and hence the direction of when to start screening.
Right.
Thank you very much, Dr. Nyakabau. Dr. Guja has raised his hand. Can you go ahead, Dr. Guja?
Thank you very much, Prof, for the lovely talk as always. And thank you very much for the clear presentation, clearly demonstrating the benefit of HPV testing compared to VIA and cytology. I think your presentation was so clear. Mine is just a comment that I think, especially in the public sector where there are means, we should move more and more towards HPV testing in view of this very, very clear data that you have presented of the benefits of the superiority of HPV compared to VIA and cytology. Thank you very much, Prof. It was lovely to hear from you.
Thank you, Bavon. It's great to hear your voice. You know, somebody has also just asked about cost, and they are you see, there are many countries have in fact bought the gene expert for TB detection. So South Africa has about 250 machines that our previous Minister of Health bought for testing for TB. You can use that exact same technology. All you need is a different reagent to do HPV testing. But if we're going to really aim to eliminate cervical cancer, the global health economic structures have to change. And these machines need to be made available to countries that cannot afford them. So, you know, there are a lot of economic and political issues. And somebody asked the question, what does a test cost? Well, in South Africa, if you were to do an HPV test, we are in a research setting, it's about 400 South African rand per KEFED test. So that is way too expensive. You know, it's about 60 rand, South African rand to do a PEP. So a lot of these issues need to be worked out, but one also needs to be very careful of solutions that say third rate is very good for the third world. It isn't. VIA is better than nothing, but it's not a good test. And it doesn't have good quality control. So everything is bit by bit, you know, and COVID has set us back, you know, many, many months and depleted many health economies throughout the world, not just in low income countries, but even in high income countries. And then there's just a question here in the chat. I have seen prevention vaccine for young age girls under 14 of age. Can this be effective while no screening is done? And the answer to that actually is yes. And the randomized data goes down to age 9. So girls down to age 9, but there are data on even younger girls, and it looks as if protection against high-risk HPV will be probably lifelong. But we can't, we're too early in the journey to say that. And if you don't add screening, you will save, I can't remember how many millions of lives, but if you add screening, you save more millions of lives. So the actual, the WHO strategy of combination of HPV vaccine and screening will have the best impact, but you have to look at the resources of your country and what are regional restrictions in going forward. I see Mike has joined us. Mike Chirengi. Hi, Mike.
Hi, Lynn. Nice to. No, I joined you right from the beginning. So
oh,
nice
sorry.
Yeah, so nice to see you and hear your voice. And I really want to emphasize the point that both were made about HPV testing. And one other thing, Lynn, that is very interesting is the overemphasis of cytology, which basically, even in private in Zimbabwe, the quality control is really not assured in most of the labs. The quality of cytology is really appalling, and lots of women spend so much money for such a poor performance. So, and coming back to the gene expert, they are all over Zim, but we have a structural problem. I think you actually have mentioned it. The money which is poured for cervical cancer screening in Zim for NGOs, they are deliberately really not wanting HPV testing, and for reasons best known to them. And it's probably a society like the obstetrician and gynecologists, we should really put pressure and give them time to say you must transition from visual inspection testing to HPV. But thanks for those comments. They're really powerful for the society. And nice to see you. We'll meet again on Wednesday on our regular talks with WHO. Bye.
Thank you, Mike. Margaret Pascoe, I think she also raised a hand. You can go ahead.
Thank you, Stanley. Great to hear from you, Prof. It's lovely to see you and from you, Prof. Chirengi, as well. I'd just like to inform you just of what we're doing at our clinic with the HPV DNA testing. We are moving from the gene expert. We have been doing the gene expert. We found the costs have become quite prohibitive. The cartridges have gone up. I think there's been a whole emphasis now on COVID, and so less emphasis on the other viral infections. So we have just procured a real-time PCR platform, which will look at 14, or actually 28 subtypes, so 14 high-risk HPV subtypes. And the cost of that test will be approximately $12. And the turnaround time is very quick. We'll get it within 6 hours. And we can do batches. So we can batch samples of 96 specimens. So I'll allude to it a little bit more in my talk later. But we propose that that's really the way forward, is that we look at these real-time PCR platforms and maybe just move away from the limitations that the gene expert has given us, as Lynn alluded to. So thanks very much. I will talk a little bit more about this later on this morning.
Thank you very much. Dr. Nyakabau, I saw you raised your hand. Is it down now?
No, thank you very much. I just wanted to comment on the HPV DNA to say, particularly in this COVID era, there's also the added advantage of self-collection of samples such that the risk to COVID spread is minimized. So these are some of the advantages. So we have to look at the advantages versus the disadvantages. And overall, you see that in terms of even cervical cancer elimination, the HPV DNA has got much more advantages than the pap smear and VIAC.
Thank you very much. Any comment, Prof?
No, I just saw there's a question in the chat. Would it be more cost effective than to do reflex testing only if the pap smear is abnormal? And I don't think we actually, I mean, it has been modeled. And if you do, say, liquid-based cytology followed by reflex HPV testing, you actually, it is not cost effective. So I think that what we need to do, do we need a triage test for a positive HPV test? And there's a lot of work going on. I mean, there's AMPFIRE, there are many different HPV tests around the world. Kefate's not the only one, but we actually have bought 2 machines and are using it and finding it very user-friendly. But the idea is to really try to get to one test and treatment on the same day without over-treating patients. And if we, going to ask low middle income countries to do 2 screening tests, I think we're going to run into major economic problems in managing cervical cancer elimination.
Thank you. Dr. Patience Mba, I saw you also raised your hand. You can go ahead.
Thank you very much. Yeah, I had raised my hand, then put it back down, but it's fine. Maybe just a quick question to Prof. Lynn. Personally, I've also had an encounter with patients who have had vertical transmission of HIV. And this particular cohort of young seem to be presenting much younger with HPV-related malignancies. Specifically, I've had just recently, this past month, about 2 or 3 patients have presented with perianal vulva, and we're still checking if they've got any cervical lesions. And they are much younger than the 25 you mentioned, or even the 21 is younger than 21. Do you have any such problems, and what would be your recommendation specifically for the young girls who've been on ART for a long time and then are prone to getting the HPV-related malignancies at a much younger age? And then just a quick comment to Prof. Chirenge. It was nice to hear your voice again. I was just thinking that for pushing for the HPV testing, probably we would do it together with the Oncology Association as well. Thank you.
Yeah, those young HIV positive patients, prior to the ARV access to antiretroviral therapy, those children who became HIV infected through maternal to child transmission had a lot of HPV related problems. And certainly we saw early cancers with full viral suppression and immune reconstitution. It seems to be becoming less of a problem. But I was on a call last week or week before with people in Cameroon, and they presented a 21-year-old girl with advanced cervical cancer. Now, we see 1 or 2 cases like that a year. So we don't see the cancers that often, but we see the genital warts, which are often worse than cancer or as bad as cancer because they're so mutilating. So, I think immune reconstitution is critical in those patients. Very difficult to manage, and very, very intense counseling they need regarding sexual behavior and other immunosuppressants such as smoking, drug use, et cetera, all of those things these young adolescents need to be informed about. There's also, what's on the horizon and I'm involved in a trial for a therapeutic HPV vaccine against HPV type 16 and 18. And we've just recruited 14 cases, very difficult because they have to be HIV negative. But we've shown in the study so far a 50% regression or clearance of HPV with the therapeutic vaccines. So that's also hopefully going to provide some protection to these young people.
Okay, thank you very much.
Thank you very much, Prof, and thank you very much for everyone who participated in this discussion. We had some time because we said early. I think we can take advantage and move on to the next presentation. I hope the next presenter is ready. The next presenter is a well-known clinician. She might not need no introduction. Her name is Mary Nyakabau. She's a clinical oncologist at Parinyatwa Group of Hospitals. She's a part-time lecturer at the University of Zimbabwe in the oncology department. And she's a founder and chairperson of Cancer Serve Private Voluntary Organization. Today, she brought a registrar in the Department of Oncology, and together they are going to present on cervical cancer recurrences, the lessons that have been learned so far. Dr. Nyakabau and Dr. Makova, you can take over the presentation. And to all members, it's a reminder to keep our mics on mute if it's not discussion time, so that we avoid background noise during the presentation. Thank you very much.
Thank you very much to the organizers. Thank you very much to Dr. Denny for a well-presented presentation. We actually, multidisciplinary management is key to cancer management. And this is illustrated by the cases that we are going to be presenting. And as a way forward, let's really listen to these cases, and this will be mostly a discussion for us to really come up with solutions to some of the problems that we face in our practice. Dr. Makova, who is a registrar in the Department of Oncology, is going to be presenting the cases. Go ahead, Dr. Makova.
Thank you very much, Dr. Nyakabau, and thank you, Dr. Ngwaru, for the introduction. I will present on two cases of recurrent cervical cancer, which we hope will underscore the importance of multidisciplinary team management of not only cervical cancer, but other cancers as well. So the first case is Mrs. JMM, a 47-year-old lady from Highlands, Harare, who's into market gardening, who was diagnosed, who had a TAH for stage 1B cervical cancer 8 years ago rather. So this is a patient who was diagnosed with stage 1B cervical cancer in October of 2012. Histology at the time was moderately differentiated squamous cell carcinoma. She had a total abdominal hysterectomy at the time, but of note, no pelvic nodal dissection was done. She then presented 6 years later in August of 2018 with clinical left-sided deep vein thrombosis. And she then had a CT scan, which revealed a mass and para-aortic nodes with left-sided hydronephrosis. The pelvic mass had appearances which were suggestive of a psoas abscess. So she then was seen by surgeons who took the patient for laparotomy and they drained the abscess. Also, multiple biopsies were taken intraoperatively, and histology revealed a recurrent squamous cell carcinoma. She was also incidentally diagnosed with systemic lupus erythematosus by physicians, having presented with suggestive symptoms. So post the drainage, she had a repeat CT scan, which showed that she did have a residual mass, which was still suggestive of an ileopsoas collection, although from the CT description by the radiologist, the mass had significantly reduced in size. She was then, however, noted to have a further cortical thinning of the left kidney, which was also hydronephrotic, and imaging revealed multiple axillary, supraclavicular, and pelvic nodes, although biopsy of the nodes that were sampled showed just reactive changes and no evidence of malignancy. And her latest imaging did not show evidence of metastasis to the lungs, liver, or bones. So the patient has, since 2018, required frequent percutaneous drainage of the abscess and on multiple occasions, and she has unfortunately developed a fistula. So in terms of salvage treatment for a patient who had developed these complications due to the recurrence, she was then commenced on palliative chemotherapy, which she was getting 6 weekly. She was receiving carboplatin, paclitaxel, and the vascular endothelial growth factor inhibitor, bevacizumab. She then received palliative radiotherapy between March and April of this year. But then because of the worsening fistula, the palliative radiotherapy had to be terminated. And currently she's not on any active anti-cancer treatment and has not been doing well because of the challenges with the fistula. So perhaps we can hold our thoughts while I present the second case, and then we can have our discussion at the end. It's also another case of recurrent cervical cancer. So the second case, it's Mrs. JK, a 40-year-old lady. She's para 3, gravida 3, a police officer from Harare who's HIV negative. She was diagnosed with stage 2A cervical cancer 2 years ago. She had never been screened for cervical cancer in her lifetime. She was seen by she was managed in government initially in one of our firms, where she received concurrent chemoradiation to a dose of 46 gray in 23 fractions with weekly cisplatin, which was followed by brachytherapy in 3 brachytherapy sessions at 7 gray per session. She was then attending 3 monthly reviews and was doing quite well until July of this year, when she began to experience an abnormal pervaginal discharge. We referred her back to gynecology for an opinion, where she was assessed and she was noted to have a cervical lesion, and biopsy of the lesion, which was noted, revealed an invasive papillary adenocarcinoma. On clinical examination at the time, I think because of the COVID, there was some break in clinical care. She was then noted to have a 5-centimeter fungating tumor. It was noted to be endophytic, confined to the upper 2/3 of the vagina, with bilateral parametrial involvement and extension to the left pelvic side wall. Her uterus and adnexa were normal sized, and the rest of the physical examination was normal. On her lab work, she had a normal cytic anemia with a hemoglobin of 9.81, with normal liver and renal function. Her urine MCS was negative, and the syphilis test, TPHA and RPR, were negative. She then had imaging, a CT scan of the chest, abdomen, and pelvis, which showed about a roughly 3 by 4 centimeter cervical tumor, which was suspicious of omental and mesenteric deposits. And the staging CT showed bilateral non-specific nodules less than 10 millimeters, which the radiologist did not think represented a metastatic deposit. She then had a staging, a pelvic MRI, which confirmed the left pelvic wall involvement with multiple obturator lymph nodes. So the patient was discussed in an MDT to weigh the options of exanterative surgery versus systemic chemotherapy. And MDT consensus was that the patient was not a candidate for surgery and has now been commenced on a palliative chemotherapy, paclitaxel, carboplatin, and bevacizumab. So after presenting both these cases, we thought we would reflect on some of these points which Dr. Nyakabau thought would be important for us to consider. The importance of MDT meetings before and after surgery, the standardization of treatment, and the importance of oncological surgery training, and for us to look at post-operative chemoradiation indications for patients who may require adjuvant chemoradiation after hysterectomy, and the multidisciplinary follow-up of patients. Thank you very much for your attention.
Thank you, Dr. Makova. I think also of importance is the examination of the pathology report, besides also what is the standard surgical procedure. Perhaps before I say much more, we would like some comments on either case from the floor so that we can actually have a discussion before we sort of like say our thoughts to the House. Do we have any takers? Dr. Kuja, would you like to comment?
I think my only comment is I think we do MDT meetings, and I think they are open for both private and public patients. So basically my point I think is people are welcome to present their cases before and after treatment. So it's not just for government patients, but people in private should feel free to present their oncology patients before treatment. Thank you.
The problem we had with this patient, the first patient who actually who died last week after a torrid time having palliative care, and I referred her to a palliative care physician, and the questions that they kept asking was, why did the doctor not refer us to the oncologist when after the operation or even before the operation? And as a clinician, you have the dilemma of spelling out what you are thinking. I mean, I agreed with the patient in terms of, yes, the patient maybe should have been referred so that we would have had a team to manage the patient. But you are, on the other hand, trying to remain professional so that, because also it's damaging to the patient when you tell them what, unless it is the doctor who managed the patient saying it himself. I cannot say it on behalf of the patient. And what the aim of what I'll be doing is to make sure the patient is holistically well in terms of their mental well-being as well. So you sort of maybe try to, I don't know, say things that are flowery to try and make the patient not focus on what happened, but focus on what we are doing now. Prof. Chirenge, I see, do you want to comment? I think you were also involved in managing this patient.
Oh, yeah, well, thanks, Anna. Yeah, it's very, very unfortunate and sometimes clearly quite depressing. Yes, I got involved in her, and the little that you personally have to tell her that you can't tell her that the way it went wrong is the substandard care she received in terms of the surgical part of the treatment. And I mean, it's just, I think the numbers unfortunately even more in private, that I think those in private end up seeking care and we tend to see them. But I don't believe that it's also not in government. But the question, I think Dr. Guja, the point that you have to realize is that I think training maybe has to change radically, not even maybe, training has to change radically. When there's a diagnosis of cancer, it doesn't matter which site, whether it's cervix or is endometrium or ovarian, there's got to be a tumor board before any treatment is done. I think that's where it goes wrong. And I think it's worse in private where it's individualized. And some will claim that I've done so many, and the problem is we don't know what has happened to them. So the point is, even if it's in private, in most countries that have good standard care, it's not acceptable to go to any form of therapy without the pathologist, without the oncologist, without the surgeon, without the radiation people, I mean, the imaging. It's a team approach. Then we say this is suitable for surgery. So Dr. Guja, I just wanted to go back to say, if we don't correct the teaching, whether it's in government and private, I don't think we'll control this mess, because it's really a mess. When you see a patient with ovarian who has had a funnel-steel incision by a well-competent gynecologist, you just know something is wrong with the training, because ovarian cancer occurs in 4 quadrants of the abdomen, and we are taught that even in undergraduate. But for reasons best known to, when it comes to practice, it's something else. So yeah, it's so good you guys came up with these cases, and I hope it will really assist us with thinking, and the society has to take a bigger role in audits and saving these people's lives, because this woman should be alive. Thanks, Anna.
Thank you very much, Prof. My next question is, who should do extended hysterectomies or VATAMS hysterectomy? Who should do cancer surgery? I mean, that's a question that I would like to hear from the gynecologists themselves, because I'm not going to be prescriptive. We have been seeing quite a few problems, and I mean, at least we need answers to say, okay, I mean, someone who is saying they are competent to do that surgery, and who measures the competence? The pathologist measures the competence initially in terms of, they will say, okay, these are the minimum these are the minimum specimen, these are the minimum things that have to be done on a VATAMS hysterectomy. Are there lymph nodes that have been dissected? What are the margins like? And all those things. I mean, at least the monitoring and evaluation part comes from the pathology report. But we also need to decide, as gynecologists, who should do cancer hysterectomy?
I give that one to Bothwell. Bothwell?
Okay, thank you. So I think it all comes back to what Uncle Mike has said, that no patient should have cancer treatment without a tumor board. So, and the tumor board should meet before and after treatment. So the thing is, if the surgery is done and the patient is presented in a tumor board, then it kind of like becomes apparent whether the surgery has been done appropriately or it has not been done. It has not been done appropriately. Like what you have rightly said, we need to see how many lymph nodes have been removed. We need to check we need to check. So there are a number of things that when you go through the pathology report, you know whether this was adequate surgery or this wasn't adequate surgery. So I think it still comes back to what Uncle Mike has said, that I think every cancer patient must not be treated without being discussed in a tumor board. I just want to highlight another case that we discussed in the tumor board, I think on the 30th of December. It's a lady who went with a positive BIAC. No colposcopy was done. She was immediately taken for TAH. TAH was done, and actually the results showed that she had an adenocarcinoma. And the patient, so lymph node dissection was not done. The patient was not told of the results, that she has cancer, and not referred for a different treatment. She then presented with an adnexial mass and gross ascites with imaging findings suggestive of cervical, of sort of like ovarian cancer. But it's only when we discussed this patient in the tumor board that she had a previous adenocarcinoma of the cervix that was diagnosed, and the patient wasn't told. It then became so apparent that this was possible. There was a possibility now that this could be a mate to the ovary with all that ascites and stuff. So I mean, it just highlights the importance of a tumor. So I think that's my comment. I think a tumor board is very, very imperative in the management of patients.
Thank you, Dr. Guja. Yes, I agree with you. Tumor boards are important, but I guess we all need skills for specialized treatments, specialized surgery. I mean, yes, there are people who are specialized in gynecological oncology, but maybe as an oncologist, this is just my personal feeling, perhaps those who are going to do cancer surgery can go through some training. They don't have to be gynae oncologists, but at least they should meet some minimum standard for them to be certified to do cancer surgery as a way forward. And not this is like a proactive way of dealing with the problem. And then we still have multidisciplinary teams so that at least from a public health point of view, we can have more people who can do the surgeries, but at least with some training. So I'm throwing it back to the gynae oncologists to look into this so that at least from the gynae side of things, they sort of like make sure that, okay, even if we're going to have provincial gynecologists who are doing gynae surgery, they have had some training and certification such that we sort of like proactively deal with some of these problems. Professor Denny, do you want to comment?
Yeah, and thank you. I mean, I think that we have to understand that gynecological cancer surgery requires a specific skill set. And where you have generalists operating alone and without tumor boards, you will undertreat or incorrectly treat many, many patients. So I think you have to work at a level of your College of Medicine to actually create certification policies for, and you know, what Bothwell went through in our system, he got a certificate in Gynaecology Oncology. He had 2 years of training. He had a logbook. He had to do 15 radical hysterectomies, and he is a fully trained gynaecologist. And then you have people like Mike who train themselves. But I think as we go forward, it's critically important, and there's a big movement in global surgery that the right skill set is developed for your MDT, so that you don't actually harm women by doing the wrong surgery. So I strongly support you, Anna, and I can imagine as a radiation oncologist, it can be very frustrating when people do the wrong surgery or inappropriate surgery or don't have the skill. So I trained somebody, for example, who came from Nigeria, who told me that every time they did a simple hysterectomy, not a cancer hysterectomy, a simple hysterectomy, they always had 2 units of blood on standby. And when I started training him, I was absolutely horrified at how he had been trained to perform surgery. And we fixed that very quickly. And he became a very competent gynecological cancer surgeon. So we need to create opportunities. We need to create centers of excellence. And we need to work with our colleges to provide the certification process for our MDTs.
Thank you, Lynn, for your comments. And I just want to reiterate that MDT is effective if there is symmetry of knowledge amongst the members. So, I mean, you may have an MDT, and if some of the people who are key in the MDT might not have the level of knowledge of what is being discussed, it may not be as effective as it should be. So in terms of cancer training, perhaps there is need for us to also look at some training in basic oncology for maybe the people who might be involved in the MDT, such that they've got enough information about oncology for them to then be able to participate in the MDT meaningfully, because then we'll be talking on the same level. Any further comments on the first case? Dr. Mba?
I just had a small question, Dr. Nyakabau. So was the gynecologist who operated on this particular case informed of the mishaps and problems that ensued on this particular patient, because they might keep on doing what they did, doing simple hysterectomies on somebody who was requiring at least probably a type C hysterectomy. This is a 1B1, right? And adequate surgery, where they informed to avoid future problems like this.
Thank you very much. Thank you very much, Patience. Yes, this was done. And because this is not an isolated case, this is the reason why we decided that we should bring it to the society so that we can work together. And I don't think in terms of individualizing who has done what is more important is way forward. You know, I mean, we all make mistakes, and many times we make the mistakes inadvertently and maybe not knowing. And I think what is important is for us to then see how we can actually prevent such mistakes. And this is the reason why we decided to bring this case for discussion, so that we can all see what we're talking about and then walk together forward.
Yeah, thank you very much.
Any further comments on the first case, or we just go to the second case, where this is a case that was given chemoradiation at our department. And I mean, the patient was treated with the standard treatment, that is external beam radiotherapy and brachytherapy. And perhaps looking back, we are saying, is there a role for those who have completed their chemoradiation, us having an MDT to assess the patients? Because I'm looking at perhaps if we had discussed this patient with the gynecologist, maybe, and followed this patient up together, well, minus the COVID problem where patients were not attending routine follow-up, we could have diagnosed this recurrence earlier and prevented, you know, the huge expenses, you know, thousands of dollars that these patients are actually paying for bevacizumab-based chemotherapy, which is not even curative. Perhaps we could have been able to do radical surgery. And also, looking back, I'm looking at our radiotherapy facilities and appealing to our gynae partners in the sense that we all need to speak with one voice to advocate for us to have working radiotherapy machines through and through, because we have got lots of challenges with the machines in terms of service contracts and many other accessories, such that we can be able to treat the patients meaningfully and with us feeling that we've done the best for a particular patient. As it is now, we have got one machine that is working, and we need at least 3 machines working at Parengato Hospital. We need a new machine. So let's all advocate that we get machines that are working full-time without any problems, and we'll be able to actually treat and make the quality of life of the cervical cancer patients better, and we'll have more survivors who will advocate for more people to take up screening and everything. And we will all be much happier than we are now as far as cancer management is concerned. Any comments on the second case? Dr. Makova, do you want to say something?
Thank you very much, Dr. Nyakabau. I think maybe just to emphasize what you have said, how I think we already have MDT structures in place, but I think we've also had challenges due to the COVID, where we were not able to have our MDTs as we used to in the pathology museum and where we get to meet physically. But I think it's an important opportunity that we've had to share these cases and to strengthen our MDT structures, not only for gynecological malignancies, but for malignancies in other systems, and to also work with other specialties to improve cancer care. And I think it would also be prudent to have decentralization of some of these cancer services to provincial level. It's unfortunate that we only have one radiotherapy machine working in Zimbabwe, and even that is a huge backlog of patients. Some patients actually have to wait for up to next year for them to commence treatment due to the challenges of having one machine. So just to emphasize the importance of multidisciplinary management of patients. Thank you.
Thank you very much, Dr. Makova.
I think I just so when I was a fellow with Prof Denny, I used to attend a Thursday clinic in the afternoon where we used to see patients treated with chemoradiation jointly with the radiation oncologists. So we'll be in the clinic. So these patients, I think once they've been treated, I think the take-home message is they should be followed up very closely. So, and the follow-up should be joint between the radiation and the gynecologist. So I hope as the COVID, whatever problem is coming to an end, it's something that we should look at replicating next year, where these patients probably we have a clinic for them when they are then seen by a combination of gynaes and radiation oncologists, so that we monitor them closely and possibly detect the recurrences early. I want to say I learned a lot from that clinic. I used to see women who would present with spontaneous VVFs 10, 20 years post their radiation treatment, would present with fistulae, intestinal fistula many years after treatment, persistent bladder, persistent bowel symptoms. So I think something that we need to replicate. I really learned a lot from that combined clinic at Krutiske Hospital. So I think we should kind of replicate something like that when we follow up patients jointly that have been treated with chemoradiation or surgery. Thank you.
Thank you, Dr. Guja. I mean, also, this can also be a platform for research in terms of long-term effects, and that research informs clinical practice and also policy. So, I mean, it will be a very good move to take up. I don't know, in terms of time, how are we doing, Mr. Chair?
I think we are just on time. I was about to interject. So if you have realized that, I'm happy that you are time conscious.
Thank you very much. I think I don't have much more to say unless there's anyone else who needs. I would just like to thank everyone for listening to our reflections. These are just reflections that have been ongoing for a long time, and I'm happy to say that we have been able to at least verbalize them, and hope that this is the beginning of a new era where we can all work together towards a better life for the cancer patients in Zimbabwe. Thank you.
Thank you very much, Dr. Nyakabau and Dr. Makova. And let me appreciate the passion that you have shown, the passion that you can actually touch it when you're talking. And I'm hoping that people will take this passion and make it, turn it into clinical practice, so that we have a radical change in our clinical practice, and also try to give patients the optimum surgery whenever it's possible. Thank you very much, Dr. Nyakabau, for such a wonderful presentation. And I'm not going to go into discussion because it was already a discussion and she managed to handle that well. So our next presenter is Dr. Mary Pascoe, who is a public health specialist, a clinician with a master's in public health, in special emphasis in maternal and child health care. She has got over 25 years experience working in the public sector in Zimbabwe, and her work has been focused in area of infectious disease in the past 15 years, more specifically in HIV with a special interest in women and children. She currently holds a position of medical director at the Newlands Clinic, which is a family-centered HIV care and treatment center, working collaboratively with the Ministry of Health and Child Care. She's going to present on the next half an hour. So she's going to present on imaging gynecological oncology challenges in women living with HIV care at Newlands Clinic. Dr. Margaret, it's your time. You can.
Great. Thank you very much, Stanley, and good morning, everyone. Good morning to my colleagues. I'm grateful for the privilege and the honor of presenting at this prestigious forum. And I hope that the presentation and the things we'll be discussing will also inspire us, challenge us, and then motivate us to take some steps forward, as Dr. Nyakabau has done. So thank you very much. I'm about to share my screen. Is my screen visible?
Yes, we can see it. Yes, we can go ahead.
Okay,
Yes.
great. Great, thank you so much. Mr. Chair, I'd appreciate if you just help me with timekeeping. I'm not particularly good in that area, so thank you. I'm talking about emerging gynae oncology challenges in women living with HIV, and we'll be sharing experiences from an urban clinic in Harare, Zimbabwe. And I want to say I was inspired by doing this by just meeting Dr. Guja at a Ministry of Health Technical Working Group forum, and then by spending some time last year with Prof. Denny's unit at Krutskia Hospital. And then I realized that we're really doing as little as we can possibly do in the public health sector, and I hope that this talk will challenge us to take some steps further. So my outline of my presentation is I'll just do a very brief introduction. I won't labor this because Prof. Denny covered a lot of the statistics that I'll talk about that in this presentation. I'll just set the context for the patients that we're going to talk about, share briefly some data. We've done a brief data analysis. And share some case studies. So the photograph just shows the entrance to our Women's Health Center, which is integrated in an HIV clinic. So approximately 10 million or over 10 million people are accessing art in sub-Saharan Africa every single day. And we have now developed technology which enables point-of-care diagnosis and monitoring of HIV disease, and that is occurring, resources permitting. So there's improved art formulations, fixed drug combinations, once daily treatment, much less side effects and toxicities that we saw a decade or two ago. So women living with HIV should actually expect to live a normal lifespan and go about their activities and daily lives as normal. But are they, is the question. We've heard a little bit about cervical cancer and the burden. We still know it's one of the commonest causes of cancer, and certainly in our part of the world, commonest causes of mortality. And the majority of these cases are in women living with HIV. But today what I'm going to emphasize on this particular presentation is the epidemic that's crept in silently and unnoticed. We talk a lot about the cervix, but what about other anogenital malignancies? We know that people living with HIV, and particularly women living with HIV with other viral co-infections, are at an increased risk of developing malignant disease. And we can talk about lymphomas, Kaposi's sarcoma, and hepatocellular carcinoma, all linked with oncogenic viruses at another forum. But today we're going to talk about anogenital malignancies linked to HPV infection. And Prof has so brilliantly outlined what that actually looks like. Looking at our context of the Newlands Clinic, we are an urban-based clinic. We established in 2004, going into our 7th year of operation. We do operate under the guidance and the auspices of the Ministry of Health and Child Care, and we provide family-centered care to approximately 7,000 patients at the moment. Our clinic is predominantly nurse-led, and the photograph shows the clinical team. Nurses, we have doctors who supervise the nurses and review complex cases, all out initiations in any complicated disease. And we try, our aim is to provide comprehensive care. So by that I mean looking at OI diagnosis and treatment, HIV care. We have an on-site lab and pharmacy where we can do the pertinent investigations and provide medications. The SRH services, which I'll speak to in the next 2 slides, are part of our comprehensive care. We do have a mental health and department, a nutritional and educational support we provide as and where we can. We are part of the National OI Art Treatment Network and are a center for treatment of third line, patients failing second line art and third line. And we do have a research and training department. And I'll talk about one of our research papers recently published. So let me double click on the SRH service that we provide. This is provided for both HIV infected and uninfected patients, and this is part of our Newlands Clinic HIV prevention strategy. We are guided by 3 specialists. We do not operate independently. We have 2 gynecologists which help us and provide weekly consultations and clinics, Dr. Siti Maguri, our eminent president of the SSOG, and Dr. Guja, who's on this call, our gynae oncologist. We also work in conjunction with a specialist physician in genitourinary medicine, Dr. Sarah Lowe, who's been really pivotal and instrumental in us setting up our SRH services and taking us to another level. We provide on-site STI screening and diagnosis, and this is with the Gene Expert nucleic acid amplification tests, and we provide that for gonorrhea, chlamydia, and trichomonas, and provide treatment for those, and an anogenital wart clinic. We provide comprehensive family planning and cervical cancer screening. We do provide a See and Treat program. Initially, when we started in 2011, it was based around the VIAC, and that's what we have been doing and are still doing to date. But we're currently in evolution and moving to HPV DNA as a primary screening tool. I don't have time in this presentation to talk more about that, but I did mention in Prof's presentation about the new platform with the real-time PCR that we will be moving to, and implementation will start in January 2021 if all goes well. So the photographs below just are snapshots of what we provide. The first photograph shows just cryotherapy for anogenital warts. These are a patient with anal warts. There's the insertion of hormonal implants. That's what one of our VIAC room looks like. We were using predominantly cryotherapy, but we've moved across to the thermal ablation, and that's our thermal ablation tool. This is a wonderful device because it doesn't require power. We can charge the battery, and we can do 100 procedures using this thermal ablation device, and then we just need to charge the battery after that. So for those who are working with cervical cancer early lesions in the field, this really is a great device. We expanded the SRH service in January of this year by acquiring a laser, this carbon dioxide laser technology. And we use this for HPV-related both benign and then pre-malignant anogenital disease. And the photograph on the left hand side of the screen shows actually, I think that's Bothwell there, when we had training when we set up the laser clinic in January of this year, and this just shows a patient undergoing laser treatment for anogenital warts. In terms of our DNA prevalence, until we get the real-time platform, we're not really sure for the whole cohort. But we did look at a small cohort, and this is a research that started some time ago, but we just completed it and was recently published a week ago, I think, in the South African Journal of HIV Medicine. And this was a paper that just looked at cervical HPV prevalence. What were the risk factors and outcomes? And when we're talking about outcomes, we're talking about VIAC positivity rates in our cohort. We screened 321 of our women, and we used the GeneXpert platform for the screening. We had a prevalence rate of approximately 25%, and 65% of those patients had high-risk HPV other than 16, 18, or 45. And we were restricted by the call-out, so I don't have a breakdown of exactly what those other subtypes were. I won't go into the independent risk factors. I think we all know what those are. So my question that I really want to propose to the forum today is, have we been so focused on the cervix that we've missed other pathology, the other anogenital silent epidemic that I alluded to in my introduction? So we looked at our data with women with vulval HSIL from January 2015 until the end of last month. And we had 44 women who had histology biopsy of lesions that looked suspicious. The median age of these women was young, 42 years. And I just want to highlight the HIV disease control. The median viral load in this cohort of women was undetectable, and the CD4 count median was 474. So I'm talking about women who are younger and who are doing well on their art. So we had no reason to sort of suspect that there was anything going on. These women all had vulval lesions and had histology, and I've just summarized here the treatment modalities that were used. Some had extensive lesions at the time of diagnosis and required surgical excision. Some had smaller lesions. We could do that with the laser under local anesthesia. We had 2 with advanced lesions that we needed to refer onto PARI, to our central hospital, for chemoradiation. We did cauterization on 2. 6 had laser therapy where we could, it was early stage low-grade lesions, the smaller lesions with no invasion. We used the imiquimod cream in a couple of patients, and I'll show you a case with that. 3 had cryotherapy, and we've got 5 who are a new diagnosis who are pending treatment. So of those lesions, we had 23 patients that had vulval squamous cell carcinoma. I want you to note on this slide the age of those patients. The median age was 37 years. They were also, again, a cohort of women who were well controlled in terms of their HIV disease, within a median cell count of 475 and an undetectable viral load. The median duration of this cohort on ART was approximately 7 years, and over half of these women had a history of genital warts and had previous histological analysis which showed vulval high-grade lesions. So we're talking about a cohort of women with either benign disease or lesions which have progressed over time. So this graph just shows the breakdown of the anogenital pre-malignant and malignant disease, and these are by diagnosis. I want you just to note the wide range there. Just one patient with vaginal high-grade lesion, and this occurred post-hysterectomy for cervical disease. She had recurrence in the vagina. We had 5 patients with penile cancer. As you can see, I've included the men because HPV is not only confined to our female patients. We've got early grade anal lesion, 7 patients with anal cancer, and amongst those, these 2 males and 5 females, 23 cases of vulval cancer, 44 patients with vulval high-grade lesions, and I put the cervical data in just to compare. Obviously, the cervix still remains our main focus, with 201 cases of high-grade cervical lesions and 40 cases of cervical cancer. I want to state that I don't think this data is representative of HIV clinics across the country, because we've become known as a referral center, particularly with the expansion of our services and acquisition of the laser machine. Patients are being referred to us. So this data, I'm not sure, is truly representative of other ART HIV clinics. Apologies. Right, so I would like to move in, and Mr. Chairman, if I do have time, just to discuss some case studies with you. My first case is a 42-year-old woman. She was referred to us. She'd been on ARVs for a year. She was on a first-line ART regime, doing well with HIV. And her story, genital urinary history, was that she was seen at a local clinic with a complaint of genital ulcers. And I looked through her clinic notes. She had on 4 occasions been treated for genital ulcer disease, given syndromic management, had 2 syphilis tests, both were negative, and she had been given 4 rounds of antibiotics, including 2 benzathine penicillin injections. This is the pictures that we saw when we examined her. You can have a look at the lesion here that was diagnosed as, well, labeled genital ulcer. You can see the surrounding edema in the clitoral area, the suprapubic area, and I put this, oops, I just couldn't read that. I put this photograph in because it shows that she had inguinal lymph node involvement. You can see the induration area in the inguinal area, and this second photograph is just a close-up of the lesion. Her biopsy showed a high-grade lesion with carcinoma in situ. She was referred to the oncologist for chemoradiation. She did well initially, but unfortunately developed complications, and we lost her 2 years later. My second patient is Mrs. P.S., a 42-year-old school teacher. She started out, as you can see, 13 years ago, doing extremely well on ART. There's her parameters in terms of her HIV disease control. She presented for routine cervical cancer screening and had been coming regularly. All her cancer screenings, which was based on VIAC, were negative. In 2017, it was noted when she came for cervical cancer screening, there was a single hypopigmented lesion was noted on the vulva. This was fairly new to us 5 years ago, so 3 years ago. So we did a biopsy not knowing really what we were looking for, and this biopsy showed a high-grade lesion. There was no signs of any other inguinal lymph node involvement or multifocal disease, so we gave her a course of 16 weeks of 5% imiquimod. So the left-hand photograph shows the lesion, and this is post-imiquimod. And currently, to date, she's well, disease-free, and the lesion has not recurred. My third case is Mrs. H.K. She's a 46-year-old woman, and she started ART in 2013. She is currently still on her first-line ART regime, doing well on her HIV. She had cervical high-grade disease, and she had LEAP procedure done, both in 2013. It recurred, and it was repeated in 2014. In 2015, she was VIAC negative at the time, but she was noted to have vulval lesions. And I just show you a photo of the vulval lesions. Of note, she has multifocal disease, both in on the left vulva and on the right. You can see in this photograph, we biopsied these lesions, and it showed high-grade lesions with carcinoma in situ. And she was referred to the gynecologist for vulvectomy, which she underwent, and she is doing well to date. The fourth patient is a 51-year-old woman. She's been on long-term ART, as you can see, for the past 14 years. Once again, extremely well and healthy in terms of her HIV. She was referred to us 3 years ago for the management of genital warts. She had been taken by her children to South Africa, to a clinic there, and she had cauterization of these warts in 2013 and 2014. They were then biopsied, which showed high-grade lesions, and she was prescribed imiquimod, and then she returned home in 2018, and she was referred to us. This is the picture that we saw, and this is in January 2018. As you can see, widespread disease, high-grade lesions, and she was referred for valvectomy, which she underwent at the Public Health Institute, and this is her post-valvectomy. She remains in care and she remains well. My fifth case is a 34-year-old woman. She started out 8 years ago, is, as the other previous cases, doing well on her treatment. She was referred to us a year ago with a 5-year history of genital warts. She comes from a rural setting, so she had not received any treatment there. I think they had no treatment modalities there. At her baseline, when we saw her in terms of her HIV disease, once again, she was well controlled. This is the lesion. The left-hand slide just shows the lesions she had with a combination of manifestations of HPV-related disease. We biopsied the lesion, which showed a mixed picture of HPV-related pathology with condyloma. She had a high-grade lesion, which was amounting to carcinoma in situ. We referred her to the gynecologists, and she underwent bilateral total valvectomy. She subsequently had a lot of complications related to her surgery in terms of vaginal stenosis and marital discord, and we don't have time to really talk about those. But that's just some of the complications that these patients face post-surgery. Our sixth patient is a 34-year-old patient, been on ART for about 7 years, doing well on therapy. She was referred to us by a private gynecologist, and once again for the management of anogenital warts. She had undergone cervical cancer screening prior to the referral, and she had a pap smear which showed no evidence of any high-grade lesions or any cervical disease. This is the examination findings that we saw. This was in March this year. You can note both vulva are involved with, I'm not sure that I would describe it as warty tissue, but there's a mixed pattern here of disease. We biopsied her. It showed a high-grade lesion and because there was no cancer, just a high-grade lesion, we opted to treat her with the carbon dioxide laser therapy. We were suspicious of the one lesion, particularly on the right vulva, and we did a second biopsy at the time of doing the laser surgery, and that second biopsy came back as positive for moderately differentiated squamous cell carcinoma. So she was referred for valvectomy, which she underwent, and this is the photograph post-valvectomy. So we're closely monitoring her. We don't have HPV DNA on her, but we're assuming that she has high-risk HPV disease. So she is being closely monitored in our clinic. My seventh patient is a 34-year-old woman. She is currently a sex worker, has been on first line 7 years ago. She subsequently failed that and was switched to second line ART. She has multiple sexual partners, has had numerous treatments for sexually transmitted infections, and she is currently doing well on her second line ART regimen, as you can see from that data there. So when we saw her, this was the examination findings. We were a bit worried about a lesion here on the right vulva and extending into the groin area. She's got multiple satellite lesions of HPV. So we did a biopsy of this lesion earlier this year, and the biopsy came back, as much to our surprise, as a high-grade lesion with moderately differentiated squamous cell cancer. We did radiological staging, which showed that she also had bilaterally enlarged inguinal lymphadenopathy. She had a valvectomy that was done, and lymph node dissection was also performed. And so this is her photograph post-valvectomy, which was just done recently. As you can see, the date on there is October 2020. So she is being monitored in her recovery post-surgery. My last case is a 47-year-old divorcee. She started ART 8 years ago. She's on second line, doing well on her ART, although her CD4 count is just above 200. And she was referred to us in May this year for the management of a vulval lesion. Her background history is she had had previous cauterization of genital warts in the private sector. but it appears that she had financial constraints and she could not be followed up. And she then came to see us. This was the lesion that we saw on her initial visit, and this was in May of this year. As you can see, it was highly suspicious for malignant disease, and the biopsy showed vulval squamous cell carcinoma. She underwent a vulvectomy and lymph node dissection, and she was referred for chemoradiation. Her lymph nodes were positive for tumor. But currently, as Dr. Nyakabau had spoken to us about, the radiotherapy machine is not functional. So she's currently undergoing palliative chemotherapy, which thankfully she does seem to be responding to. The tumor bulk is shrinking, and we're awaiting the functionality of the radiotherapy machine at Parry for her to undergo further treatment with combination chemoradiation. So I've just presented this case series rapidly because I wanted just to concentrate on really that it's not only the cervix that we need to be looking at, but we also need to be looking at the other anogenital areas. And this is, I think, needs to be put on people's radar screens, particularly for training. The first patient that I presented, she had been treated for genital ulcer disease for 4 times, and when I asked her, she had never actually undergone an examination. I think she had just presented with her complaint in a local clinic, and the reflex is to write genital ulcer syndromic management. And so my appeal is that we take these patients seriously when we treat them, and if there's no improvement with our therapy, that we do a thorough examination for these patients. So, Mr. Chairman, with that, I'd like to conclude this presentation, and I'm very happy to take any questions or comments.
Thank you very much, Margaret, for a wonderful presentation. Yeah, if there are any comments, let's have some comments. I think we are only left with 4 minutes, and then we'll move to the next presentation. Any comments?
Sorry, I can't raise my hand. It's Dr. Landman from Well Woman. Margie, thank you. That was brilliant. And not just your presentation, but the work that you're doing. Can I just ask the audience, for HIV negative women with HPV disease, is there anywhere to go nationally, anywhere that would offer a similar service? And do you think there would even be a demand for that? Do you think there's any kind of burden of anogenital HPV disease in HIV negative women? And where would they go to get such an equivalent high standard of care? Women who can't afford it. Private care, can't afford private care.
I think in the HIV negative group of women, I think what you're going to commonly find are probably anogenital warts, but they might not be as extensive as the ones that Margaret is seeing. But unfortunately, to answer the question is, where do you refer them? I think everybody knows that there's been complete dysfunctionality of the hospitals because of the COVID and other issues that have not been addressed for some time. So we hopefully that the next year will bring some good news and restoration of some function. The University of Zimbabwe runs a colposcopy clinic, which is done every Monday and Thursday. There's also another government colposcopy clinic, I think that's done on a Wednesday. So I hope when normal business resumes, I think some of those patients can be referred to those clinics, but we don't have access to laser. That's why I think Margaret then presented some of the patients that were referred to Parry some time back. I think I wasn't there then, who ended up having some valvectomies. But I think Margaret, maybe you can come in. I think you are happy to see HIV, even negative patients who need laser treatment.
We're sort of in evolution. We have such a high burden of disease at the moment in our HIV positive women that are being referred to us. So for now, we'll just have to look at our capacity as we move forward into 2021. but definitely we can do assessments and then provide recommendations in conjunction with yourself, Bothwell.
Okay, I think I can raise my hand. Margaret, I just want to say thank you very much for a very lovely presentation. And thank you very much for all that you are doing for these ladies. I just have got 2 comments. I think we tend to see a lot of women with vulval HCL that have been referred and treated as flat warts. One of the things that I learned during my fellowship training was Prof. Denny said there's a rule of the vulva that you must biopsy, and biopsy. So if there's a lesion that you're not so sure of, especially something that you think they are flat warts, there's a possibility that could actually be vulval HCL. So if you're not 100% certain about the diagnosis of any lesion on the vulva, I think it's safe and prudent to always do a biopsy. And my second comment is about surgery for vulval cancer. One of the most important part of this proper surgery for these patients is doing groin lymph node dissection. And I want to add that you cannot replace groin lymph node dissection with radiotherapy. I think there was a GOG study which clearly showed that of those patients who don't have groin lymph node dissection and are treated primarily with radiotherapy, the recurrence rates are higher. And if a patient recurs in the groin, I think it's almost always fatal. So I think proper surgical treatment for vulval cancer should include groin lymph node assessment, and if they are appropriate, then they should have groin lymph node dissection. One of the things that was happening in Cape Town when I left, but unfortunately we can't replicate it here, is for women with small tumors less than 4 centimeters to have them to get sentinel lymph node biopsy instead of the extensive groin lymph node dissection. But initially I was very hopeful that things would change and would move towards that. But I think there have been some challenges that have been insurmountable. But I think the take-home message is that groin lymph nodes have to be assessed, and groin lymph node dissection is one of the most important part of the surgery in terms of achieving good outcomes. Thank you.
Yeah, thanks for that. And I just want to say thanks for an excellent talk, Margaret. And you're doing a sterling job for these women. I mean, from the onset, when it was set up, I used to visit quite a bit, and I am just very impressed with the standard of care you've provided for our population. But just the question on the HIV negatives who have perianal disease. I just want to give reference to one of the students that supervised Rashim Mandishora, who is in Lyon, France, for a postdoctorate training in HPV molecular work. Did some work where we have data on burden of disease, both on vagina and anal among HIV negative cohorts, but she was comparing with HIV infected. And I also reference you to my other student I co-supervised, who's now a general surgeon, Dr. Chinyoa, who did anal, and very fascinating data on anal intraepithelial neoplasia and anal cancers. And I also point out that in the cancer registry, there are actually more women with anal cancer that who acquire anal cancer in terms of incident cases than men. So, really, the going back to what Professor Denny said in terms of screening for HPV among HIV negative, both for anal and the talk will go long, but in fact, Simba has gone on to do pap smears on anal, and as a parallel, and it's a fascinating area where, going back to Margaret's talk, a woman who's HIV infected, yes, should be really looked at thoroughly, but don't also forget that you can also sample the anal and refer for proctoscopy and biopsies because there can be background noise in there. So, and lots of them really who are HIV negative in their 20s, the HPV, I mean, will regress, so that's the good thing. But if they are HIV positive, as we all know from what Lynette and Denny said, they need to be looked at. But my emphasis both for one day, maybe we can present data from Rachel and Simba. Thank you.
Okay, thank you,
Thank you very much. Thank you. Sorry, both for that. Thank you very much, everyone. I think this is a very interesting topic, and thank you very much, Margaret, for such a wonderful work that you're doing there. But for the sake of time, I think we can continue the conversation in the chat box. So we ask our next presenter, Mary, who is Mindray, a clinical specialist for English Africa. She's got 15 years experience in clinical practice with diverse knowledge. Mary, may you please take the stage and share with us your presentation.
Okay, good morning, everyone. Can you hear me?
Yes, we can hear you.
All right, good morning once more. My name is Mary Goretty, and I'm the Clinical Application Specialist for English Africa. Today, I'm going to take you through Mindray Women's Health Solution, and this is specifically on ultrasound. So you realize that this group of patients are sensitive, they are easily irritable, and at times they are very impatient. Therefore, we need to make them as comfortable and safe as possible. And therefore, I'm going to give you a solution for this from Mindray. So we are going to look at Mindray platform and finally the Mindray features, which have the solution for women healthcare. So these are all the Mindray ultrasound products that we have, from value range to premium level. We also have portable black and white, and we have tablet. All of them can do women healthcare imaging. So we look at the features that we have in OBSGYN, and the features are geared towards high image quality, strong and soft tools, and powerful outflow to sort out the women. So because of this, we have two platforms that we introduced. This is the first one is ZST platform, and the second is X Insight platform. I'm going to talk in details about them. And because of this, we've been able to achieve good Doppler imaging, which includes HD scope and glazing flow. We've also been able to achieve automatic measurements of obstetric anatomical parts that we do measure, CNS, ICV, face, pelvic, follicles, SCV, and iPage. And also the feature iLive, Highline, and HiCosi. I'll talk in details about this, but we are able to do this by just a click of one button instead of the manual way of doing the measurements. And also, because of the powerful outflow in our equipment, we have what we call MedSight, MedTouch, there's iWorks, and UltraView. And these are all solutions to women's scanning. Main challenges that you have in women and children health includes in gynecology and reproduction, in pregnancy, in postpartum, and finally in neonates. So in gynecology, there's usually a challenge of increase in the proportion of infertility. We have challenge in diversity of etiology and the need of more accurate diagnosis. While in pregnancy, we have challenge of increased number of elderly and large women. We also have increased risk of deformity and the need of high diagnostic efficiency. And finally, in this segment, we also have women who are very worried about their safety for scan. So we are going to give you a solution here today. And in postpartum, we have a challenge of pelvic floor function disorders found not in time, and also lack of standardized inspection protocol. And after giving birth, we also have the neonates who are always with their mothers, and there's poor cooperation of these neonates and difficult to complete examination quickly and accurately because of lack of cooperation. And therefore, we have the ZST platform. This ZST means zonal sonography imaging. So what happens in this, that image acquisition is in zones rather than the single emission of sound waves like before. And therefore that has enhanced quick scanning, quick acquisition of the images, and therefore even the moving patients or moving body parts, we are still able to see to get quality, while we also achieve on penetration. And again, we have a wide variety of ultrasound transducers that are used in women and child health. And these ultrasound transducers have high quality color flow sensitivity. So this ZST platform works on 4 pillars, which are geared towards, the first pillar is geared towards advanced acoustic acquisition. The second pillar is geared towards dynamic pixel focusing. And the third pillar of ZST is geared towards sound speed compensation. And finally, the fourth pillar is geared towards total recall imaging. I'll explain this, I'll explain bit by bit. So in advanced acoustic imaging, look at the images. We are able to see just by simple scanning, we are able to get details of the part that we are scanning. It's extremely fast in processing the information and accurate display of anatomical motion and hemodynamic states, therefore reducing tissue motion artifact. So most of the machines, the frame rates are very high, and therefore even with the motion of the body parts or motion of the patient, we are able to acquire quality image. So in the second pillar, I talked about dynamic pixel focusing. As you can see in these bars, you don't see any focus. So the machine is intelligent enough to recognize and to identify your focal point and automatically focuses it. And therefore the struggle of doing the manual focusing is gone. And this is found in our premium equipment. And because of this, there's also improved penetration and image quality. And in pillar 3, the sound speed compensation is achieved. Now remember, ultrasound travels in different wavelengths, and therefore the speed is also different. And the system is able to compensate with this difference in speed and makes us acquire or process the data accurately and at a good speed. And therefore image acquisition is superb and optimal to tissue specific. And that is the zonal acquisition of the image. Now, in the fourth pillar, which is the total recall imaging, as you can see, we are able, just by one button, we are able to get clarity of the part that you want. As for example, this is a neonate brain. In this first image, you are not able to see some details because of blurring, but here, just by a click of one button, we have sharp edge of the brain. And this applies to all body parts. Now, in prenatal diagnosis, the main challenges that we have is lack of high quality tools for fetal brain analysis, and therefore it takes a lot of time to do brain analysis, and some people give up and go to MRI, but ultrasound can do this. There's also difficulty in obtaining standard sections. And therefore, we have a lot of intelligence and also automatic measurements. Then also the tedious. This has been a main challenge for a long time, the tedious measurements. The manual measurements in obstetric and gynecology is quite tedious, and it takes time and it requires a lot of involvement. And if you're a learner, it becomes a challenge. And therefore, we have a solution for you. There's also worry of scan safety. Many mothers asked, for example, many times when you send them for serial scanning or repeat scanning, they ask you if the scan is safe for them. And I'll show you, the Mindray machines gives you degree of safety limit for ultrasound. And for sure, ultrasound has a safety limit. And therefore, I'll show you on Mindray equipment, we demonstrate the safety limit just on the monitor. So the solution to what I've talked about is the first acquisition with autofocusing, and therefore you get clear images while you focus automatically, and this saves a lot of time while you achieve on quality and penetration. And also the improvement in the color sensitivity, we have what we call glazing flow. As you look at this image, it looks like a three-dimensional color flow, while it is a two-dimensional color flow. And this is very important. For example, when you're assessing very tiny vessels, it is very, very helpful in assessing the very tiny vessels, and therefore you cannot miss your diagnosis unless experience is also missing. And this is also very useful when you're doing Doppler studies in obstetric. And I know one challenge is always the middle cerebral artery identification. So you can make good use of this glazing flow. It will not fail you. It will identify even the very tiny vessels in the brain. It's a very good function. Then there are smart tools. These smart tools, there are automatic measurements in obstetric and gynecology. So I'll talk about the obstetric first. And one of them is, I'll talk about the obstetric first, and I'll start with the HD scope that I talked about earlier. Look at these two images. This second image, the HD scope is off, and therefore you are seeing a bit of blood image, and you're not able to clearly identify the two tissues of different echogenicity. And here the HD scope is on, and you're able to clearly differentiate these two different echogenicities within the structure. And this is the heart of a fetus. This second image, the first image here, the HD scope is off. And this was a scanning of ectopic pregnancy. And you see here, you are not able to clearly distinct between the ovary and this adjacent lesion. Here, the HD scope is on, and you're able to clearly differentiate this lesion adjacent to the ovary, and hence better diagnosis and more accurate diagnosis. Now, I talked about the ZST platform, and I said this acquires image in zones rather than the single emission like many other ultrasound machines do. And what do I mean by zone? Look at these two images as we go on. The first image here is the image acquisition in singles, and therefore you see a bit of blurring of the image, and there's nothing you can do about it. But we have a solution for that. Just by one click, and you get automatic focalization. This is a zonal scanning. The image is acquired. There are several zones that are used to acquire one image, and therefore you get clarity. You achieve on clarity, you achieve on penetration, while you take less time to scan this patient. And therefore you don't have a challenge with the diagnosis because of the distinct differentiation of the tissues. Now, again, the ZST platform, this I talked about, you see the clear, distinct differentiation between these two different tissues of the organ. This is the glazing flow I was talking about. This is the old conventional Doppler, color Doppler, and this is the glazing flow. And this allows you to see even the tiny vessels. And again, the acquisition for this is very fast, and therefore frame rate is very, very fast. And we have been able to achieve in fetal echo. There's no challenge in scanning in fetal echo because of the very high frame rates in the equipment. Now, the smart tools I talked about, you're able to measure the three basic anatomical landmarks, which includes the head circumference, the biparietal diameter, the abdominal circumference, the femoral length, and the other advanced measurements, just in case you need to add more advanced. You can still do the automatic measurements by just click of auto measurement, and the machine automatically recognizes what you want to measure and do it for you. You don't have to do adjustment, but you still have an option of doing your adjustment. But now the trick with this is that you have to get very good two-dimensional image quality for you to achieve correct automatic measurement of the parts that you want. Then again, in Smart CNS, you just get one standard anatomical landmark for the head. That is the one that you use for the head circumference in BPD, and the machine will automatically get you the other three images. And you press calculation and it will automatically identify the parts that you're supposed to measure in the central nervous system, and it measures for you. And it is actually more accurate than the manual measurement. But remember, your first image must be accurate and it must be of good quality. Then there is the smart intracranial volume that the machine is also able to do. And this one is done in 3D, 4D imaging. The probe that does this is the 3D, 4D. And therefore, this one also, you just get one anatomical image, then automatically, once you press the smart ICV, the machine will automatically detect and calculate it for you and give you the measurement for intracranial volume. And this is what I was talking about. And this is very useful in diagnosis of microcephaly. This is the same thing. Therefore, it is efficient, it is accurate, and you're confident with the diagnosis. Then there's the smart sim. Again, the machine automatically detects the part that is under investigation. For example, if it is the spine, it will identify the spine where you're measuring, and you just focus there and automatically it will give you the view that you want. That is the smart sim. And it adjusts the region of interest automatically. Then there's the iLive Pro. Now the iLive Pro, again, there's improvement of this. This is also in 3D, 4D, and there's improvement on this such that, you know, initially we had to direct these spotlights, the point lights, and now we are able to get auto focus of these lights at all directions. But you still have the option of moving these spotlights or point lights to different directions depending on what you want to see. And these are also examples of other images. Now, this is the volume light on, the automatic lighting, and this is the volume light off. And as you can see, this image is very pleasant to the eye than this. Then the smart tools I talked about, the automatic measurements that we have, I'll stress on the smart nuchal translucency. I know nuchal translucency, you check between 13th week and, between 11th week and 13th weeks and 6 days. And we have automatic measurement for this. As long as you get a nice two-dimensional imaging, just go to measurement, click on smart nuchal translucency, and it measures for you, and it's very accurate as long as you are accurate on your two-dimensional image. Again, the smart OB, this is a smart measurement of the anatomical parts that I talked about. This one, you just click measure, and Once the bar comes, you just click auto measurement and it measures for you, and it's very accurate. Unless your 2D image is not clear. Now, there's also smart plane fetal heart. This is also acquired in 3-4D imaging. So you get a nice 2-dimension, just one view of the fetal heart. You click on the smart plane and it gives you all the other views. And this is very good feature in obs-gyn doctors who are also doing fetal echo. And we have smart face in 3D, 4D. So once you get baby's face, you just click smart face, then it will remove all the artifacts on the baby's face, and you remain with a clear baby's face or clear fetal face. And this is just a demonstration of the smart face. You see here there are artifacts, and once you click the smart face, the artifacts are gone. So that is the work of the smart face, just by click of one button. Now, the image acquisition is also very fast, and therefore it still works for fast-moving babies. You know, at times you can't control, actually all the time you can't control fetal movement, and therefore with this fast acquisition of the image by the ZST platform, you are able to acquire even babies who are moving fast. Now, there's the function called iPage. Now, this iPage function is very useful in obstetric. Actually, it's also very useful in gynecological work, but I'll talk about obstetric this time. It looks like CT scan. Just like CT scan works, is the same way the iPage works. It shows the slices of the parts that you're scanning. For example, this green light shows that it tells us the slice that is on this green light. And this is very useful. For example, if you have a lesion or a tumor, you're able to see the start of that tumor, the appearance of that tumor on every slice to the end of it. And this allows you to achieve up to about 25 slices. And it's very useful in diagnostic. I talked about safety of a mother. Mothers keep asking, especially when you send them for serial scanning, they keep asking if scan is safe. Yes, scan is safe if you use it wisely, if you use it well. So Mindray gives you a solution to display the safety of the scan to this mother. In case your settings are wrong, then there's what we call thermal index. This thermal index, usually the safety, upper limit of the safety is up to 1. So when you see 1.0 displayed, then know that the safety limit, you are going beyond the safety limit. And all the Mindray equipment that have Doppler, we have display of this. This is the power of the machine. And remember, when you go very high in acoustic power, also the tissue thermal index goes high. So we display this at all times. Don't worry about this mechanical index, because this one only goes beyond limit when you're doing contrast enhanced studies, because this thermal index is the ability of ultrasound to cause cavitation in a tissue, and mostly cavitation can occur when you're administering contrast agent. And ultrasound image will always, Mindray ultrasound machines will always display this and also warn you about the upper limit of the safety. And therefore, this is a solution for you, and it's displayed at all times. In postpartum imaging, you find that there's a large proportion of pelvic floor functional disorders after childbirth. And this is up to about 35 to 50%. And this has been a big challenge in many countries, and mainly manifested as pelvic floor relaxation that affect urination. But this might not be discovered in time. And therefore, we have a smart solution that can make you discover this. As long as you clinically diagnose this, you're able to discover it effectively and efficiently. And this includes, pelvic organ prolapse, stress urinary incontinence, sexual dysfunction, and fecal incontinence. Now, the main challenge here in scanning, you're able to diagnose, but we have main challenges in scanning of this, the manual scanning. And these challenges are many measurements that are required and which is time consuming. And also it is difficult to detect the reference line for accurate results. Then again, in levator hiatus evaluation, we have challenge of time and challenge of poor repeatability. And we have a solution for this. And solution is auto evaluation package for the anterior compartment. And also auto evaluation package for levator hiatus. Just a click of one button once you get your start point, and it will do all the measurements for you automatically and accurately. And that is part of artificial intelligence. And this one will be displayed later in video form, and therefore you'll see how it is done. So automatically the machine, once you get the good 2D, it will do all the other measurements for you.
Hi, Mary, can we round up? Sorry.
Yes, we are winding up. Then in gynecology and reproduction, we have a challenge of increased proportion of infertility, diversity of etiology, and the need for more accurate diagnosis. We also have the manual detection of follicles, which is not easy, and you might have double calculation. And solution for this is auto calculation of the follicles. Sorry, I didn't display that image, but we can, oh, here it is. The smart follicle. You get, and this one is done in 3D, 4D with a 3D, 4D probe. So once you get a nice 2D with a nice follicle, you just darken the image a bit, click smart follicle, and it detects all the follicles for you. It will give you all the measurements plus the volumes and plus the number of the follicles. And therefore it's very easy. Again, we have a solution for infertility, checking. This is hysterosalpingo contrast sonography, whereby you inject contrast as you do the 3D imaging in GYN, and you're able to see the tubes. And in case there's blockage, you'll be able to detect at this point. And also with this, you also can demonstrate the hyaline. You see, it looks membranous, and this is a very nice feature. We also have elastography in GYN solution, and elastography you can tell in case there are cancerous lesions within the cervix. You're able to use elastography to demonstrate that. You can also use the 3D, 4D imaging for, this is endocavitary. You can use it to detect uterine morphology, the structure of the uterus. And it's an easier way of diagnosis of the uterus anomalies. Then there's the smart volume. At times you have a challenge of telling whether the endometrium is thickened or not. Now we have just one button to take the volume for you, and you'll be able to tell the endometrial volume. Now in neonate, and this is the last point, we have dedicated transducers for neonates. This is neonatal cranial transducer, and this can also be used in the abdominal scanning. And it gives us very clear details of the neonatal brain structure. Then we also have very high frequency linear transducers, which can be used to scan neonate lungs. Remember, many times people go for the CT scan, which is radiation based, and therefore we can avoid this by doing ultrasound, and we have this solution for neonate. And also neonatal hip ultrasound can be done, and you get, once you acquire this 2D image, click on smart hip, and it does all the measurements for you. You no longer do the manual measurements. you know, at times manual measurement becomes accurate, especially if you are not sure of what you're measuring. Then we also have the neonatal cardiac solution, very high, with very high frame rate. And there's no longer challenge of color imaging. And we have the X Insight solution, and here we have the DC60, we have DC70, we have DC80 and DC80A. And here, the X Insight, most of the transducers like the convex, the cardiac, and the convex cardiac and the 3D, 4D are all using a single crystal transducer, which allows you to penetrate as well as retaining image quality. Or the old system have a challenge of when you have a difficult patient, when you really need to penetrate, you lose in the quality. But this X Insight has a solution such that you achieve on penetration as well as retaining the quality of the image. So in conclusion, in summary, in pre-pregnancy phase, we have the elastography solution. We have the enhanced ultrasound contrast imaging. We have the smart volume trace, and we have smart follicle. In pregnancy, we have smart planes. In central nervous system, we have smart IVC, intracranial volume. We have smart phase. We have iLive. We have glaze flow, and we have smart nuchal translucency and obstetric measurements. Then again, in postmortem delivery, which is a challenge, and still it is a very big challenge, and we have introduced solution for this, and which includes auto-evaluation of anterior compartments, and also auto-evaluation of the levatus, hiatus. And finally, in neonates, we have dedicated transducers and smart hip, which is the automatic measurement of the hip. Thank you, and we only sell what we know can do well for our customers. Thank you.
Thank you very much, Mary, for such a wonderful presentation. I think because of the sake of time, maybe we'll allow 1 or 2 questions. If there are any participants who are interested, who want to ask some questions. I don't see any raised hands, and I don't see anyone coming in to comment. Oh, there is Dr. Jojovic. You can go ahead. Hello? Is she still there? Dr. Jojovic, are you still there?
Yes, good morning. Thank you very much, Mary, for wonderful presentation. Which contrast are you going to use for a saline sonography, or would you use, if you are not using saline sonography, for sonographic measurements and evaluation of the cavity and the tubes?
Okay, for the sonogram, we use normal saline, and for sure, normal saline is a simple solution that is safe for all patients. Then in the contrast enhanced studies, we use what we call SonoView. This is a new introduction in Africa, and it is now in use. I'm not sure if it has, if Zimbabweans have started using it, but it is in use, and it's quite efficient in diagnosis, especially in diagnosis of benign and malignant tumors.
Yeah, and then you will need a 4D transvaginal probe, correct?
Yes.
Yes. Okay, so would you be able to get that? Yeah.
Sorry, but for the contrast enhanced studies, you don't need you can use the 2D probe. But for the other one, you need the 3D, 4D probe.
Yeah, sure. Yeah. So would you be able to get that contrast for us? Because we are struggling with the South African XM films. They're not giving us such a good images, and we cannot assess tubes properly.
Okay, for the tubes, we use normal saline, and I guess normal saline is everywhere in Zimbabwe.
With the 4D probe? With the 4D transvaginal, or, yeah?
Okay, so that we'll discuss with the sales team, with our local partners in Zimbabwe and our sales leader for Mindray, and they'll give their feedback. They are in here and they're listening.
Thank you very much, Mary. Thank you.
Thank you
Cheers.
very much. Thanks. And any other question?
I don't see any raised hands.
Okay.
Mary, I think that was a very wonderful presentation, and we want to thank you for such a wonderful presentation.
Thank you, Stanley. And before we finish, I would like to invite all of you to video show about our women healthcare solution during lunchtime. So please stay tuned. Thank you.
Thank you. I think we'll take a short break, and we'll come back at 20 past for the next session, and Dr. Gwanzura will be the chair at that moment. I want to thank you everyone for paying attention during this session, and wish you all the best in the day. Thank you. Let's break for some tea, and then we'll come back at 11:20.
Okay, thank you so much, Stanley. Before we all go, I just want to emphasize that there are some of you who are logged in using your phone names instead of your real names. If you may kindly maybe re-log in and put your real name, this helps with our collation of participants' data and CME certificates once the conference is done. So please just check how you have logged into the conference. If you are using your phone name, just change it to your real name. Thank you. See you after the break.